Hello and welcome. My name is Dr. Sherif Negm. I'm a professor of obstetrics and gynecology at Cairo University, and today I will be talking to you about lower female genital tract infections. First, we'll discuss a few of the defense mechanisms against the ascent of infection. These are known as the natural barriers that protect the female lower genital tract against the ascent of infection. The first barrier is the vulva, which contains apocrine glands, which are modified sweat glands, and these produce fungicidal acid that prevents the proliferation of fungi. Also, the apposition of the labia closes the introitus, forming a mechanical obstacle against the ascent of offending organisms. The vagina, as you know, is a potential tubular cavity, and the opposition of the anterior and posterior walls also acts as a barrier against, or mechanical barrier against the ascent of infection. The vagina is also lined by stratified squamous epithelium, which makes it more resistant to infection. Also, the vagina is acidic in the pH, and this prevents the overgrowth of offending bacteria and fungal infection. The flora inside the vagina is usually gram-positive lactobacilli, and this splits glycogen into lactic acid and gives the vagina its acidic pH character, thus helping it to ward off any infection. The cervix is also closed by a bacteriolytic cervical mucus, which is a thick cervical mucus plug that also acts as a mechanical barrier against the ascent of infection. Also, the endometrial cavity, the periodic shedding of the endometrium during menstruation eliminates any possible infectious organisms that may have found their way up into the uterine cavity. When are these defense mechanisms compromised? During childhood and after menopause, because of the absence of estrogen. Of course, before puberty, there's a hypoestrogenic state as well as after menopause. And due to the deficiency of estrogen, there is a decrease in the glycogen conversion into lactic acid. And thus, this makes the vagina more alkaline, and because it is more alkaline, it is more prone to overgrowth of offending organisms such as bacteria, fungi, and other parasites. The endometrium, of course, is fully developed or atrophic and does not undergo cyclic shedding, so any offending organism inside the endometrial cavity is more liable to proliferate and flourish. Also at the time of menstruation, because the menstrual fluid washes out the cervical mucus plug, making the endometrium more amenable to ascent of infection. Also, the menstrual fluid, because it is alkaline, it lowers the vaginal acidity, making it more vulnerable to infection at that time. At the time of the purpurium, because the uterus, cervix, and the vagina are more widely opened and dilated, and because the vaginal acidity is neutralized by alkaline lochia, and of course because of the big raw placental site and the presence of lacerations in the lower genital tract, all these factors with the lower genital resistance because of the inhibited immunity at the time of pregnancy, all these make the female patient more vulnerable to lower genital tract infection at the time of purpurium than other times in her life. The first infection we'll talk about is vaginitis, which is infection of the vagina, and this may be either primary or secondary. And primary vaginitis is divided according to the time of its occurrence. During childhood, it is known as Vulvovaginitis of Children. During the reproductive period, the vagina may be affected by a variety of organisms such as Trichomonas vaginitis, monilial infection, bacterial vaginosis, purpura infections, and others, more specific organisms such as gonococci, TB, syphilis, and bilharziasis. In the postmenopausal period, as in the childhood period, there is also senile vaginitis due to atrophy of the stratified squamous epithelium and drop in the vaginal acidity, making the vagina more alkaline and prone to infection. Secondary vaginitis. Secondary means a spread of infection from a neighboring infected organ, and the most commonly associated organs or related organs to the vagina are the urinary tract and the rectum. So if you have a vesicovaginal fistula, then the patient is liable to have vaginitis. Also, if he has a rectovaginal fistula or complete perineal tear, this makes him more liable to have recurrent bacterial infections. Presence of pessaries or tampons may also act as a mechanical factors that harbor bacteria and prevent their expulsion, resulting in vaginitis. Chemical irritation, especially douches. They neutralize the lactobacilli and make the vagina more prone to infections, especially fungal infection and bacterial vaginosis. The first thing we'll talk about is the vulvovaginitis of children. It is usually affected by non-sexually transmitted organisms such as E. coli, staph, and strep, but sometimes they can be sexually transmitted such as gonococci and trichomonas. Oxyuris infestation, which usually spreads from the lower gastrointestinal tract or the rectum, may also cause irritation of the vulva by causing severe pruritus at night. The predisposing factors include the presence of foreign body, because sometimes children may introduce inadvertently foreign bodies inside the vagina, and these may harbor microorganisms resulting in persistent foul-smelling discharge and infection. Also, because of the absence of the vaginal acidity, the vagina is more alkaline because of the absence of the protective effect of estrogen on the vaginal epithelium. Also, poor hygiene, spread of infection from maybe urinary tract infection may cause infection of the vulva, resulting in vulvovaginitis. The mode of infection, it may be from infected towels, it may be from, as I said, urinary tract infection. Sometimes you have to rule out the presence of sexual molestation, especially if you find sexually transmitted organisms such as gonococci and trichomonas. The clinical picture, the girl will usually complain of severe itching. Sometimes it is bloody and sometimes, beg your pardon, associated with bloody vaginal discharge. There is sometimes there is also dysuria, but this may point to the fact that this may primarily be due to a urinary tract infection. On examination, you'll find foul vaginal discharge with severely inflamed vulva and the vagina. If the girl is complaining of pruritus mainly at night, then you have to be suspicious that this could be due to an oxyuris infestation, and this can be diagnosed by a cellulite test at night, where you may be able to see the pinworm coming out from the anal orifice and slowly creeping towards the vulval area. The investigations. We usually don't do investigation unless the vulvovaginitis is persistent, and in this case we do an ultrasound and X-ray to detect and exclude the presence of a foreign body. Investigation to detect oxyuris, maybe a stool analysis, culture and sensitivity of discharge, and of course don't forget to do a urine analysis to exclude urinary tract infection. Treatment, of course, is that of the cause. If you have oxyuris infestation, you give treatment for this kind of infection. If there is a foreign body, you remove it. If there's only E. coli infection resulting in vulvitis, then systemic antibiotics that are active against E. coli ought to be able to deal with this problem. Of course, you have to advise the parent that local cleanliness with diluted antiseptics is very important, and in the future, local cleanliness is also very important. If you notice that the vagina is very thin, And then maybe estrogen therapy for a short period of time with ethinyl estradiol in small doses for a month may help build up the epithelium of the labia and the vaginal introitus and help to prevent the occurrence or recurrence of this type of infection. Senile vaginitis is vaginitis that usually happens after menopause, and the organisms are varied. It may be due to various cocci or gram-negative bacilli. The symptoms similar to prepubertal children, they will have vaginal discharge, which is with sometimes spotting and pruritus, and if they are still sexually active, they'll have also dyspareunia. On examination, you will find that the vulva and the vagina are atrophic with loss of the corrugated appearance of the vaginal walls. And if you touch the vaginal wall gently, there may be some serous discharge indicating that there is atrophic vaginitis. Investigations, you have to exclude the presence of a genital malignancy by doing a pap smear, especially if the cervix looks suspicious. Colposcopy or vaginoscopy may also be warranted if you think you have the patient has a localized lesion. Sometimes you have to do a dilatation and curettage if you note that the blood or the discharge is coming from the endometrium, then dilatation and curettage may be warranted to exclude an occult endometrial cancer. Culture and sensitivity of the discharge is very helpful because it will guide us to the choice of antibiotic. The antibiotics, usually ampicillin or cephalosporins, are usually sufficient because, as we said before, the majority of these patients are infected with staphylococcal or E. coli infection rather than sexually transmitted infections. Topical estrogen therapy may be also of value in these patients similar to prepubertal vaginitis to help build up the vaginal epithelium and the labia, making it more resistant to recurrent infection. Also, lactic acid vaginal douches, 1%, will increase the vaginal acidity and make it more resistant to infections. Trichomonas vaginitis, this is a very common cause of vaginitis during the childbearing period or in sexually active women. It is responsible for 25 to 50% of cases of vaginitis, and the organism is a flagellated tropozoid protozoan known as Trichomonas vaginalis. It is ovoid and motile and flourishes in weak acidic medium with pH of 5.5 to 6.5. That is why one of the predisposing factors is vaginal douches that lower the vaginal acidity. The site of infection, it may affect the vagina, the urethra, the skinny tubules, bladder, and the cervix, and the mode of transmission is usually through sexual intercourse. The clinical picture, it has an incubation period of 3 to 28 days, followed by very characteristic symptoms. The patient mainly complains of profuse, yellowish, malodorous vaginal discharge with mild pruritus, vaginal soreness, dyspareunia, and very characteristically also dysuria. On examination, if you look at the vagina and the vulva, they'll have all this manifested. The investigations, what we usually do is do a wet mount examination, take a drop of the vaginal discharge and place it on a slide, and this will usually show a motile organism with leukocytes. If it is a stain with Gimsa stain, you can see the characteristic flagellum and can be cultured with special broth media in order to confirm the diagnosis. You can see here, this is the organism, and you can see that it has flagellae or tails or tail at the back and flagellae at the front. The treatment, metronidazole, is usually effective. Usually give 500 milligrams every 12 hours for 10 days or a 2 grams single dose. And you have to remember that this is a sexually transmitted disease, so you also have to treat the male partner at the same time. Another dose possibility, if you're afraid that the patient will have compliance problems, especially her husband. You can give her tinidazole, 2 grams of a single dose, and this was found to be just as effective as metronidazole. Clotrimazole, vaginal pessaries, can be used during pregnancy and lactation instead of metronidazole because some studies have found that metronidazole may be unsafe, especially during the first trimester of pregnancy. Monilial vaginitis, commonly known as candidiasis, it is usually caused by Candida albicans in about 90% of cases, but other organisms such as Candida glabrata may be responsible for 10% of cases. And this, unlike Trichomonas, which flourished in weak acidic media, here it flourishes in a strongly acidic media. The incidence is the second most common cause of vaginitis, and the mode of infection, actually the candida may be present in the form of spores inside the vagina, and they start to flourish once the situation or the environment inside the vagina becomes more acidic. This results in the spores being transformed into hyphae or pseudo-hyphae, and they become active and cause the infection. So any predisposing factor that causes an increase in the vaginal acidity may cause this kind of infection to flourish. Sometimes there's also candidal infection in the lower genital tract, resulting in repeated infection, what is known as auto-infection. The predisposing factors, any factor that affects the vaginal microenvironment. For example, antibiotics, which are very well known to cause an attack of thrush or candida infection, because antibiotics will kill the protective lactobacilli and thus make the candida uninhibited and potentiate their transformation from spores into hyphae, causing candidal infections. Oral contraceptives also increase the glycogen in the vaginal epithelial cells, and as glycogen increases, there's increased production of lactic acid by the lactobacilli, resulting in increased vaginal acidity, making candidal infection more possible. Pregnancy also is associated with high estrogen level, resulting in increased glycogen production, and any condition in which the patient's immune system is suppressed, such as steroids and immunosuppressive therapy, will lower the immunity, making the individual more susceptible to candidal infection. Diabetes, because it has a double effect of increasing the glycogen deposition in the vagina and lower the immunity. Thus, patients who are diabetic, especially uncontrolled, will probably more liable to have recurrent attacks of candidal infection than other individuals. Also, lack of proper hygiene, of course, is a factor in the current attacks, as it is in other types of infections. The clinical picture here, the main symptom rather than discharge is actually the presence of severe itching and scratching sensation on the vulva. The patient will also complain of the presence of a thick, curdly, adherent whitish discharge, sometimes similar to cottage cheese. They also complain of dyspareunia and sometimes also dysuria. On examination, there is vulvitis, redness, edema, and itching. The vagina is also very red and tender, and very easily this can be easily diagnosed by finding these adherent white cottage cheese-like discharge adherent to the sides of the side walls of the vagina and over the cervix. The investigations, this can be diagnosed by taking a drop of the discharge and plating it on a slide and adding 10% potassium hydroxide. Gram-positive spores will be diagnostic if you find gram-positive spores, and long pseudohyphae. If you find only spores, that means it is not an infection, just dormant candidal spores, but you have to find long pseudohyphae to indicate that, as you can see here, the long pseudohyphae The presence of these long pseudohyphae indicates that there's actually an active candidal infection on wet preparation of microscopic exam. A stained film with methylene blue will also be helpful, and culture on Feinberg-Whittington media is also very helpful in diagnosis. The treatment, you have a myriad of antifungal treatment, whether oral or topical. Mycostatin or nystatin, vaginal pessaries, 100,000 units every 12 hours for 2 weeks, then once daily for 2 weeks. Or tablet form, 500,000 units, 3 times daily for a week, or to treat the intestinal candidiasis, because as we said, sometimes it is harbored in the intestines, especially in patients with recurrent attacks of candidiasis. In these cases, it is best to give them oral treatment because it also will affect the intestinal reservoir for the candida. Imidazole derivatives such as ticonazole, clotrimazole, and miconazole, vaginal tablets and cream are also very effective. Fluconazole, orally, single oral dose of 150 milligram for recurrent or persistent infection, but of course the oral treatment should be avoided during pregnancy because it may harm the baby, especially in the first trimester. If the patient has a fungal infection during pregnancy, it's best to avoid the oral fungicidal drugs and focus mainly on the topical treatment, such as the vaginal anti-fungal pessaries. Also, you can give gentian violet 2% aqueous paint or alkaline vaginal douches. Sometimes also betadine vaginal douching may be of value, especially during pregnancy. Bacterial vaginosis. This is a non-specific vaginitis, previously known as Gardnerella vaginitis. The incidence is the most common cause of vaginitis. 30 to 60% of women in sexually transmitted diseases clinics will have some sort of bacterial vaginosis with other superimposed infection. The organism, it is actually not a true infection. Rather, there's an alteration of the normal vaginal flora, decreasing the lactobacilli and allowing the overgrowth of an organism that is a normal commensal of the vagina but becomes more transformed from a commensal into a pathogen. This is Gardnerella vaginalis, together with anaerobes, which become transformed from commensals into pathological organisms. The mode of infection, it is not a sexually transmitted disease, but the mode is not completely understood, but unprotected sexual intercourse, frequent douching are possible causes. Why frequent douching? Because, as we said before, frequent douching, especially with antiseptic solution, will destroy the normal vaginal microenvironment and will help the commensals or pathological organisms to flourish inside the the clinical picture, symptoms, it is asymptomatic in maybe half the cases, but the characteristic feature is the presence of an excessive grayish, frothy, malodorous discharge, and the discharge is usually characterized by the patient as having an offensive, fishy odor. Pruritus is also less common. On examination, you have a characteristic discharge with fishy smell and signs of inflammation of the vulva and the vagina. The investigation also it depends upon the fresh drop examination. Here you'll find what is known as a clue cell, which is a vaginal epithelial cell with obscured borders due to attachment of the organism, and this is a very characteristic feature which is usually diagnostic of bacterial vaginosis. Can be also cultured on Cassman's agar or blood agar at 10% carbon dioxide. Gram stain, you'll find gram-negative rods with absent lactobacilli, and the whiff test, if you have the discharge and you add 10% potassium hydroxide, you'll have the characteristic fishy odor. The diagnosis is usually based on Amsel's criteria, 3 of the following criteria: the presence of thin homogeneous discharge on examination, pH of the discharge is usually more than 4.5 degree, more than 4.5, that is, the vagina becomes more alkaline, and the whiff test, in which you have a vaginal discharge and you add to 10% potassium hydroxide, will result in a fishy, characteristic odor. Also, the fourth criteria, the presence of clue cells on microscopy. So if you have 3 of these 4 criteria, then this is used diagnostic of bacterial vaginosis. Cram staining or for vaginal smear may also be done, and culture of the vaginal secretion has no place in diagnosing of bacterial vaginosis, because you'll find a large number of organisms, because it is, as we said, is not based on a single pathogen. The treatment is similar to that of, along the same lines as the treatment of the treatment is similar to that of treatment of Trichomonas vaginitis with metronidazole or tinidazole, also clindamycin. Local vaginal cream is very effective. Next, we'll move a little bit higher to talk about acute cervicitis. This is acute inflammation of the endocervical glands and underlying tissue. It may be caused by a large number of organisms. Most commonly, gonococcal and chlamydial infections stand out as the main causes or main pathological organisms. It may also occur in the post-puerperal period or after miscarriage or termination of pregnancy, known as post-abortive, or post-operative infection after instrumentation or cervical dilatation, cauterization, or trachytherapy. So any surgical procedure that involves the cervix may be followed by cervical infection if the complete aseptic precautions especially are not adhered to. The clinical picture, usually the patient will complain of a mucopurulent discharge with mild fever, dysuria, and backache. These are the characteristic features, and on examination, Cusco exam, you'll find that the cervix is red, hot, and swollen, with mucopurulent discharge coming out from the internal os, and there's marked tenderness of the cervix on movement, something known as cervical motion tenderness. Investigation, this can be mainly based on culturing of the discharge, looking for mainly gonococcal and chlamydial infection. The treatment is antibiotic according to the organism. Usually we try to focus on the 2 most common organisms, which is gonococcal infection and chlamydial infection. So we have to give an antibiotic treatment that covers these 2 main organisms. The complications, it commonly turns into chronic infection due to the racemose nature of the cervical gland. It also may result in secondary vaginitis, and it may spread upwards into the upper genital tract, resulting in pelvic inflammatory disease to the body of the uterus or the tubes or the parametrium, may rarely spread to the urinary tract. Chronic cervicitis, the symptoms, it usually happens after several attacks of acute cervicitis, which become chronic if it is not properly treated. The patient usually complains of mucopurulent discharge, congestive dysmenorrhea, and menorrhagia because of the pelvic congestion. Sometimes there is backache because of spread of infection along the uterosacral ligament, resulting in a characteristic low backache. Contact bleeding because of the cervical erosion sometimes happen. And there is also dyspareunia because of the tenderness in the cervix and the inflammation in the parametrium. Infertility if the cervical discharge remains hostile, and especially if the infection spreads upwards into the upper genital tract, resulting in chronic pelvic inflammatory disease. There's also sometimes frequency of micturition if the infection spreads anteriorly to the bladder, resulting in cystitis. Rarely there is manifestations of a septic focus. On examination, this is usually done by speculum exam. You'll find a mucopurulent discharge coming out from the cervix, which is known as endocervicitis. Sometimes you can find something known as cervical erosion. Mucus polypi sometimes may be seen, which are reddish with pedunculated small polyps resulting from hyperplasia of the endocervical epithelium. Nabalthian follicles, these happen as small bluish or yellowish cysts projecting on the porta vaginalis because of the recurrent attacks of cervicitis and healing of the cervix, which results in obstruction of the cervical glands, forming these distended cysts. The cervix itself becomes swollen and hyperemic, which is known as a chronic hypertrophic cervicitis. Ectropion sometimes may happen, in which the anterior and posterior lips of the cervix are everted due to bilateral cervical tears. The investigations, you have to, of course, if the patient has a suspicious looking cervix, you have to exclude malignancy by either doing a pap smear or by referring the patient to a colposcopic clinic for more complete evaluation. Culture and sensitivity of the discharge is important, and the treatment is usually based on antibiotics, or either oral or topical antibiotics together with vaginal antiseptic solution. Cervical erosion, and erosion is usually known as a cervical ectopy, as a red velvet-like area and often raw area with a graze-type appearance on the outer surface of the cervix. It is a benign non-cancerous condition that does not lead to cervical cancer. The most common cause is hormonal erosion, in which there is excessive estrogen causing the columnar epithelium of the endocervical canal to grow outward and replace the stratified squamous epithelium covering the ectocervix. Women who are taking oral contraceptive pills also may have a cervical ectopy because of the same reason, and it may also happen during pregnancy. You can see here, this is a normal looking cervix. You can see the thick stratified squamous epithelium of the ectocervix. You can see here the small red area. This is a small ectopy. This is columnar epithelium covering a small portion of the ectocervix, and here on you can see a very large ectopy. You can see the normal stratified squamous epithelium covering the remainder of the cervix or the ectocervix, and you can see the internal os here and the area around it, which is bright red because of the transformation of the squamous epithelium into columnar epithelium. The clinical picture, most cases are asymptomatic, but sometimes the patient will complain of mucus discharge, contact bleeding, especially after intercourse or douching, and symptoms of chronic cervicitis if the condition happens after an infection. On examination, vaginal examination, you will have a velvety sensation, occasionally contact bleeding. On speculum examination, you'll find either a flat erosion, which appears as a red area, or papillary erosion, which are raised folds, or follicular erosion, which are glandular distension. Investigation, you have to exclude malignancy, of course, because this is a suspicious looking cervix by doing a pap smear, and also you can take a swab for culture and sensitivity to exclude infection. If no infection is found and the pap smear is normal, then this is most probably a hormonal erosion, and the treatment only is needed if the case persists for more than 3 months and the patient is constantly complaining of contact bleeding and offensive discharge. Antibiotics if the patient has an underlying infection. Otherwise, we don't do anything, and we ask the patient to wait for the erosion to heal by itself. Cauterization sometimes can be done as a last resort, but before doing it, you have to exclude malignancy by taking a biopsy, or at least by colposcopically directed biopsy. What cauterization does is it opens and drains the infected glands if it is due to an infection, and coagulates the superficial epithelium over the site of the erosion. Now, what are the methods of cauterization? We have several methods that we can use: electrocautery, cryocautery, which is freezing, laser cauterization, endocoagulation or ZEMS coagulator, or chemical cautery. The first one we'll talk about is the electrocautery. With electrocautery, you usually don't need anesthesia because the cervix is usually insensitive to anything other than cervical dilatation, and as we don't need to do dilatation, usually do not need to anesthetize the patient. The cervix is exposed and cleaned with sodium bicarbonate, and then using a red hot electrode, 3 linear burns or incisions are made in the anterior and posterior lips of the cervix, extending from the internal os to the edge of the erosion. The depth of the cauterization is usually 2 millimeters, and this is usually followed by vaginal discharge, which will increase for 10 days. So the patient has to be counseled about that. Should not worry about the increasing vaginal discharge for 10 days, and this is followed by squamous epithelium will cover the denuded area within 4 to 6 weeks, causing treatment of the erosion. The complications of electrocautery, of course, if it is done overzealously, it may result in secondary hemorrhage due to sloughing of the scar tissue. This usually happens on about the 10th day and can be treated, especially if the bleeding is heavy, by packing and by antibiotics. Sometimes, if it is done incorrectly or too deeply, it may result in ascending infection and parametritis. That is why electrocautery also has to be done under cover of strong antibiotics. And very rarely, if the cervix is fibrosed because of the overzealous electrocautery, cervical stenosis may ensue, resulting in a retention of menstruation, later on resulting in hematometra requiring cervical dilatation. Cryocautery or freezing, this uses carbon dioxide or nitrogen cylinder. A cone-shaped probe is applied to the external os, extending into the lower part of the cervical canal, and the applied probe is applied for about 2 minutes to freeze at minus 60 degrees. This freezes the tissue to a depth of about 2 millimeters, leading to necrosis and separation of these tissues. And the healing after cryocautery is much better than electrocautery, and the complications are much less. So it's a preferred line of treatment. Laser cauterization. This is also a form of cautery, but we use a controlled destruction of the superficial thin layers of the tissue by vaporization of the cells. So it gives excellent results and does not have as many complications as with the electrocautery. But the equipment is expensive and requires extensive training. Endocoagulation or ZEMS coagulator, as you can see from the image, is an expensive machine, and what the machine here has an attached probe, and the probe is heated to 100 degrees, causes coagulation without extensive necrosis of the resulting tissue, and the results are excellent, but the instrument itself is quite expensive. Lastly, chemical cautery using silver nitrate 20% after protecting the vagina with a Ferguson speculum, because if the silver nitrate comes on the vagina, it will cause burns on the vagina and sloughing. This is a very old method that can be used for mild residual lesions. And thank you for your attention.